Hello, I am Dr. Edward Kelly, Assistant Professor of Department of Surgery at Brigham and Women's Hospital, a Harvard Medical School affiliate. This lecture will be concerned with abdominal catastrophes and abdominal compartment syndrome in critically ill patients. I have no financial interest in any biomedical or other health-related entities described in this lecture. In this lecture, we will review the 5 most common abdominal complications and go in detail of the 5th, abdominal compartment syndrome, with respect to physiology, outcomes, and treatment. In the medical ICU, abdominal complications are often misdiagnosed or diagnosed late in their course. This is due to atypical presentation of common medical complications in advanced critical illness, as well as due to the patient's vulnerable situation with an altered sensorium and an altered physiology. Oftentimes, abdominal complications require surgical intervention, and there is an increase in mortality, length of stay, resource utilization, and financial costs with surgical complications in medical ICUs. I'm going to describe here the fearsome 4, as they are called: mesenteric ischemia, enteritis and colitis, cholecystitis, and perforation. Mesenteric ischemia is the most commonly misdiagnosis of the 5 that we're going to review today and carries with it the highest mortality. Mesenteric ischemia can occur in the absence of arterial occlusive disease, and this is referred to as non-occlusive mesenteric ischemia, or NOMI. Occlusive disease in the ICU and infarction are most frequently encountered due to embolism in the setting of atrial fibrillation. Oftentimes, this is a sudden pain out of proportion to physical signs. However, it can be insidious with nonspecific abdominal complaints, constipation, melena, abdominal distension, or feeding intolerance. Often these subtle signs can rapidly progress to fatal sepsis. Non-occlusive mesenteric ischemia usually occurs as a consequence of a so-called low flow state, such as heart failure or abdominal compartment syndrome, or sepsis or some other cause. NOMI is never a sudden diagnosis. However, it can be characterized as worsening hypotension and progressive organ failure in an already compromised patient. Mesenteric ischemia carries a high mortality in critically ill patients, up to 88% mortality in the vulnerable population. Circulating markers are non-diagnostic in occlusive or non-occlusive mesenteric ischemia. Lactate, white blood cell count, base excess, CK, and transaminases can be elevated or normal. The diagnosis, of course, requires a high index of suspicion, and the most effective treatment is surgical for the occlusive diseases and resection for the non-occlusive. Diagnosis of mesenteric ischemia relies on contrast examination with CT or CT angio. There is greater than 90% sensitivity and specificity for occlusive mesenteric ischemia with CT angiography. CT can be non-diagnostic for non-occlusive mesenteric ischemia, however, can be very useful in excluding other diagnoses such as perforation or abdominal sepsis. Bedside laparoscopy has been advocated by some centers. However, this can be cumbersome to deploy at the bedside and is not always easily tolerated in the critically ill patient. Peritoneal lavage or diagnostic peritoneal lavage has been trialed, but again is nonspecific and is not as sensitive as CT for occlusive mesenteric ischemia. Occlusive disease almost always requires surgery in the form of some degree of either embolectomy or bypass. Non-occlusive mesenteric ischemia survival depends on correction of the underlying illness and resection of the compromised segment of bowel. To date, there is no reliable non-invasive test to exclude bowel necrosis in the setting of suspected ischemia. Colitis and enteritis, the most feared complication in the colon for a critically ill patient is Clostridium difficile colitis. This is an exudative inflammatory colitis resulting from the growth of Clostridium difficile in the colon, and it follows a spectrum of presentation. The most concerning is the fulminant pseudomembranous colitis, which involves significant toxicity and shock. Thankfully, this is only 3 to 5% of all C. diff colitis, but the mortality exceeds 30%. Diagnosis of C. diff colitis is characterized by nonspecific abdominal pain with tenderness. Diarrhea may be present in many cases, but is absent in up to 20% of patients. Significant leukocytosis is frequently seen, and CT for a diagnosis is sensitive but not specific for C. diff. The stool toxin assay is greater than 70% sensitive, and the stool glutamate dehydrogenase assay is sensitive but not specific. Stool culture is very sensitive but time-consuming. Colonoscopy may be used in the setting of a decompensating patient to exclude other diagnoses and to differentiate colitis from ischemia. Medical therapy is available for non-fulminant pseudomembranous colitis. This includes oral vancomycin and oral metronidazole, as well as intravenous metronidazole. Intravenous immune globulin has been attempted but is not proven for initial treatment, but may be helpful in preventing recurrence. Cholestyramine has been advocated as a toxin-binding strategy, but again requires the patient to tolerate the oral medication. Total abdominal colectomy is advocated for fulminant toxic megacolon, and timing is critical as mortality increases with delay. A strategy of diversion and abdominal lavage has been trialed in small series for the treatment of toxic megacolon. This consists of a diagnostic laparoscopy to rule out perforation and to construct a loop ileostomy. The loop ileostomy is then used to lavage the colon with polyethylene glycol, and vancomycin is instilled per the stoma, and metronidazole intravenous treatment is carried on for 10 days. In small trials, there has been a 50% survival with this treatment, and the patients have been able to have the ileostomy reverse and maintain a normal colonic function. Acalculous cholecystitis can affect 1 in 100 patients depending on the ICU population, and mortality is elevated from baseline cholecystitis up to 20 to 50%. This is frequently the result of biliary stasis and chronic distension in patients with sepsis, cardiogenic shock, hemorrhagic shock, or in a fasting state in the ICU. It's often associated with already established organ failure and abdominal hypertension. Acalculous cholecystitis results in gallbladder wall ischemia, and which can progress to necrosis and gangrene. In 44% of surgical specimen, gangrene was present in the pathology specimen. There are few reliable signs or symptoms at the bedside for acalculous cholecystitis. Greater than 90% of patients are already on a ventilator and may have some compromise of their sensorium. Fever and leukocytosis and elevation in transaminases are not reliable markers of this diagnosis. You can see a rising bilirubin without ductal dilatation in about 60% of cases of acalculous cholecystitis, and feeding intolerance and worsening organ failure without other causes are also seen. Imaging diagnosis depends on ultrasound, which can reveal gallbladder distension, wall thickening, and sludge in the lumen of the gallbladder, although rarely will you see calculi. Sensitivity is less than 90%, however, in most series. Scintigraphy with radionuclide is often non-diagnostic due to fasting or elevated bilirubin. CT with contrast does facilitate the diagnosis of infarction and gangrene and may reveal or exclude other causes, for example, mesenteric ischemia or perforation. CT findings include thickened wall, pericholecystic effusion, sludge in the gallbladder, and air in the gallbladder wall indicating gangrene. Cholecystectomy is the mainstay of curative treatment for acalculous cholecystitis. It's usually an open procedure and entails a higher risk of bleeding and biliary injury than elective cholecystectomy. For those patients who are too moribund to tolerate an open operation, percutaneous cholecystostomy may be utilized. It is less invasive and less complicated, however the mortality is still high and does not adequately treat gangrene of the gallbladder wall. This is a reasonable option for complicated patients if detected early. Bowel perforation can occur as a further complication of ischemia, obstruction, or colitis. Some bedside procedures can lead to iatrogenic bowel perforation, especially paracentesis. In the critically ill ICU patient, bowel perforation does not always cause typical symptoms of peritonitis and can be insidious. Of course, this diagnosis carries with it a high mortality and may be present as an incidental finding of pneumoperitoneum on a previously undiagnosed patient. Diffuse peritonitis can be mild or severe. The diagnosis may be marked by simply new development of ascites and abdominal distension with constipation or feeding intolerance. Plain radiography is insufficient to exclude perforation and may reveal benign sources of pneumoperitoneum. CT with intravenous contrast is the usual high sensitivity diagnostic test, and oral contrast is not necessary to make the diagnosis of perforation. Treatment of perforation is almost always surgical with laparotomy, resection, and/or diversion. Rare cases can be managed without laparotomy, such as a pneumoselective endoscopic perforation from GI endoscopy or contaminated perforated diverticulitis or contained perforated diverticulitis. Delay in surgical treatment increases the risk of mortality. Turning now to abdominal compartment syndrome, this is a clinical syndrome that results from the elevation of intra-abdominal pressure. A normal intra-abdominal pressure is 0 to 5 millimeters of mercury, but can be seen, a higher baseline can be seen in obese patients. Elevated intra-abdominal pressure can result from acute swelling of the bowel, new development of ascites, high volume resuscitation resulting in anasarca. This can be seen in the burn patient or in a patient with intra-abdominal bleeding. Abdominal compartment syndrome carries with it a high excess mortality, greater than 60%, depending on the cause for the intra-abdominal hypertension. Elevated pressure in the abdomen causes a higher wall tension, a decreased perfusion of the abdominal wall, and therefore decreased compliance of the abdominal wall. This can eventually progress to abdominal wall ischemia and necrosis, and the elevated pressure in the abdomen leads to decreased venous return from the lower body. This will, of course, impair cardiac filling and can be treated with volume resuscitation. However, this perpetuates the vicious cycle of venous engorgement of the abdominal viscera, leading to ischemia and bacteremia. Engorgement and loss of venous return from the kidneys may result in acute kidney dysfunction or frank renal failure. This also results in pressure exerted on the diaphragm, causing elevated airway pressures, hypoventilation, and respiratory compromise. Physical exam reveals abdominal distension with a firm abdomen, evident ascites, and respiratory distress with high peak airway pressures. The abdominal compartment syndrome is associated with clinical signs of shock and organ failure and elevated intra-abdominal pressure. No imaging or other diagnostic testing is necessary to make the diagnosis. Intra-abdominal pressure is often measured via bladder manometer. However, there are certain circumstances, particularly pelvic fracture, where these numbers can be misleading. Again, 0 to 5 millimeters of mercury is described as normal. Greater than 20 millimeters of mercury is described as dangerous and may respond to resuscitation temporarily, but greater than 25 millimeters of mercury, one should strongly consider decompression, as this level of pressure is associated with end organ dysfunction. Here is a bladder pressure transduction system that can be applied to the Foley catheter and used to measure intra-abdominal pressure. This system shows a simple pressure manometer. However, systems can be adapted to use pressure transducers on a typical critical care monitor. Decompressive laparotomy is required for life-threatening abdominal hypertension. This consists of a long vertical midline laparotomy and a temporary abdominal closure for relief of intra-abdominal pressure. This leads to immediate effects on ventilatory pressure, venous return, and urinary output. Survival depends on the underlying cause of the intra-abdominal hypertension, however, and established multi-organ failure is unlikely to improve with decompression. Reconstruction of the abdominal wall after the underlying cause is reversed can be challenging. Here is a typical abdominal wall temporary closure scheme. The fascia and skin are separated to enable expansion of the intra-abdominal volume. The abdominal organs are protected by a clear plastic membrane, and drainage catheters are used to remove any excess fluid that accumulates. Ongoing pressure monitoring is indicated in these patients because recurrent abdominal compartment syndrome can occur. This may be due to ongoing swelling or bleeding or inadequate decompression. Temporary closure may require tightening or loosening depending on the circumstances and the pressure measurement. In summary then, abdominal catastrophes usually appear as complications in already severely ill patients and can herald multiple organ failure. The most common causes carry high mortality and require high clinical suspicion. CT imaging with intravenous contrast is the most useful diagnostic test for all these group of diagnoses, and surgical treatment may be indicated and should be carried out expeditiously for it to be successful. High mortality still is observed despite advances in management. Review question 1. What are the most common abdominal complications in critically ill patients? A, mesenteric ischemia, colitis, cholecystitis, and bowel perforation. B, gastrointestinal bleeding, intussusception, and incarcerated hernia. C, volvulus, spontaneous bacterial peritonitis, and hepatitis. Or D, incarcerated hernia, bowel obstruction, and appendicitis. The answer is A, the combination of ischemia, colitis, cholecystitis, and bowel perforation. Taken together, these complications account for 75% of the abdominal complications in ICU patients. What single imaging modality is most often diagnostic for abdominal catastrophe? A, abdominal CT with intravenous contrast. B, abdominal ultrasound. C, abdominal magnetic resonance imaging. Or D, endoscopy. The answer is A, abdominal CT with intravenous contrast. This test has the greatest sensitivity for the 4 common abdominal complications and can be used to discriminate between them. Oral contrast does not add to the sensitivity or specificity and can be omitted in patients that are unable to tolerate. Review question 3. What is a normal intra-abdominal pressure? 0 to 5, 5 to 15, 15 to 20, or 20 to 25? The answer is A, 0 to 5. The abdominal pressure is usually low, but may be elevated in obesity or in otherwise normal patients on positive pressure ventilation. Pressures above 20 millimeters of mercury are associated with a high risk of organ failure.